welcome you to our webinar on mobile telemedicine, presenting a case study as well as reimbursement and technology updates to inform us on our journey towards wider adoption of telemedicine. Our talented speakers today include Dr. Lisa Gwynn, Director of the University of Miami Pediatric Mobile Clinic and Assistant Professor in Clinical Pediatrics at the Miller School of Medicine. Dr. Barbara Sheehan, Senior Health Researcher with Intel Corporation, and Dan McCafferty, Vice President of Global Sales and Corporate Development at AMD Global Medicine. We will be taking a few questions after all of our speaker presentations, so please capture and submit your questions at any time during the webinar. Intel is sponsoring this webinar because we're excited about the rise of telemedicine technology as a way to deliver more accessible healthcare for consumers as well as more efficient healthcare delivery for providers. Unlike telehealth, where a provider may have a simple video conference directly with a patient, today we will be talking about how AMD Global's teleclinic, Agnes software, and over 40 USB-connected medical peripherals can be used to deliver full telemedicine services. As the doctor or specialist, you can enlist trained personnel to go mobile with this solution, enabling you to effectively serve a large population. We think this technology can be integrated into mainstream healthcare. We at Intel are also excited about how telemedicine technology, including AMD Global's Agnes software, benefits from the abilities of Intel processors. In 2011, Intel integrated video memory and transcoding directly onto our CPUs, resulting in dramatic performance and efficiency improvements. Why does this matter? Because when you're using telemedicine, quality is critical. And AMD's Agnes performs, enabling multi-point conferencing, delivery over low bandwidth connections, and support for over 40 USB-connected devices. And the technology continues to improve. Advanced codec support from H.264 or AVC to 265 or HEVC is enabling 1080p and now 4K resolutions at half the connectivity bandwidth and file size. This is critically needed to support high-resolution telemedicine to many locations, and Intel processor performance is enabling this delivery with the quality of service that telemedicine requires. Now let's hear from our first speaker, Dr. Lisa Gwynn, founder and director of UMMC's Pediatric Mobile Clinic and assistant professor in clinical pediatrics at the Miller School of Medicine. Good afternoon, Dr. Gwynn, and thank you for coming.
Good afternoon, Matthew, and thank you very much for having me. I'm looking forward to sharing with the group everything that we've been able to accomplish utilizing mobile telemedicine applications. So just to tell you a little bit about our program itself, we are a pediatric clinic, a mobile clinic, and our mission is to provide comprehensive primary care health services free of charge to children most in need, specifically those kids that do not have access or limited access to health care. And our services are wide. We provide comprehensive medical care, including sports physicals. We provide immunizations. We manage children with chronic illnesses. We are acute care facility as well. We're equipped to handle any type of acute pediatric conditions. And we also have mental health as well as nutritional assessment and access to specialty care, which we'll talk more about in the upcoming presentation. So here's just a visual of our unit. And it basically has 3 exam rooms. Here's a picture of one of them. We have also a small area for nursing to be able to draw labs. And so even though there's only 3 exam rooms, we certainly get a lot done in those rooms. So basically the way that it works for us is we go into community centers, churches, we park at schools. We go into pockets of Miami-Dade County that are in need of health care. We do have quite a few uninsured children throughout Miami-Dade. And last year we had over 2,000 clinical encounters and over 200 mental health visits. We've given a lot of vaccines, especially for kids that are arriving from other countries. South Florida is a hub for international families coming in and settling. Over 68% of our patients are Hispanic, and about a quarter of our patients come from Haiti. And so we were fortunate enough to receive telemedicine equipment through a HRSA grant. And, you know, when we had this equipment, we really had to step back and think about what our need really was. And so that began our journey to kind of look into what we could offer utilizing this technology. Now, this spreadsheet's kind of messy here, but I wanted to bring the point home that we actually track every specialty referral that is made in our clinic. And what we found was, well, in the year 2013, we had over 233 referrals to our safety net hospital for specialty care. The specialties that were the most popular were cardiology and dermatology. But when we tracked those actual referrals, we found that only 35% of those kids actually went to their appointments. So we definitely were frustrated and decided that bringing in telehealth, telemedicine technologies would in fact help us to increase our compliance rate with connections to specialists. So first so just to kind of back up, I'm sure I'm speaking to the choir when I tell you what a formal definition of telemedicine is, but I think it warrants us to kind of review and step back. And basically it's the use of medical information exchanged from one site to another via electronic communications to improve a patient's clinical health status. And for us in the Pediatric Mobile Clinic, this includes a variety of applications and services such as two-way video, smartphones, tablets, integrated medical devices, which Matthew touched upon earlier, and other forms of telecommunications technologies. And so basically we had this equipment. We knew we had the need. And so how do we get there? So first of all, of course, we decided we were going to tackle the low-hanging fruit and offer specialty services to the most popular and most needed specialties. So we began our journey with the type of equipment that we felt was best, and there's a lot of different options out there. And we decided, because of our limited spacing, that the small, which I'll talk about in the next slide, a smaller, more durable unit worked the best for us. Some of the other challenges that we had to overcome included connectivity. How are we going to have appropriate connectivity on the mobile unit, especially when we go into these areas where you know, the cellular signal may not be perfect. And then, of course, making sure that we had a good technical support team working with us, that was key, as well as staffing and workflow. How is this going to affect our normal operations of the medical clinic if we were to do so simultaneously? And of course, from a physician standpoint, what always was concerning is the ability to not only offer this service, but to provide that continued clinical care coordination. Because it's one thing just to have a visit with a specialist, but it's another if they require follow-up, if they require further treatment or prescriptions written. And lastly, in addition to the specialists that would be willing to participate, because that's another barrier, some physicians are not so inclined to jump on board with this type of technology. Many feel uncomfortable with it. So really getting out into the community and finding specialists that are willing to and become champions to work with you with this technology. And I know this is going to be talked about later, but funding, of course, is always an issue, and it certainly depends on what state you live in. So there's various options of equipment, as I spoke of earlier. And for us, stationary carts, we couldn't fit a stationary cart in our unit, so we went with the portable teleclinic option. And so here's a picture of it. It's really wonderful for us. It's very durable. It has all of the applications that we need to be able to carry out a full consultation. The small picture on the left shows the peripheral devices that we are able to plug into the unit. It folds up very nicely, and we put it in a cabinet, and we go on our way. And all of these peripherals plug into the device, and so simultaneously we are able to have video conferencing as well as the specialist is able to receive that medical information from the devices. And we do utilize a couple of options in terms of the software that's required. We do utilize Agnes, and it's really wonderful because it aggregates all of the clinical diagnostic information as well as utilizing the video conferencing as well. So the specialist is actually simultaneously seeing the medical information as well as interviewing the patient and the parent. And on those, the other option that we sometimes utilize for those consultations that don't require any type of medical device connectivity, we do utilize strictly video conferencing services. We utilize Fuse, but there's a lot of different ones out there. And what I encourage all of you to do is, if you are going down this road, to be sure that the software is HIPAA compliant. And I am not a technical genius, but I will tell you I had to learn pretty quickly in terms of being able to appropriately connect our telemedicine with the unit with the technology of the internet. And so I worked very closely with our wireless carriers engineers to be sure that we had appropriate 4G LTE signal, and within the unit we outfitted it with a cradle point router, which basically distributes the Wi-Fi signal within the unit, and antennas were installed on top of the mobile unit. And I do want to say, when you're embarking on something that isn't necessarily something groundbreaking and innovative, the most important thing that you really have to do is to bring the right technical support to the table. You have to have support from both the equipment manufacturer as well as your IT department, as well as networking, and combined, it definitely is possible. And what we've found in the IT world is there are a lot of people, especially at academic institutions, that will say that it can't be done just because they don't know how to get it done. So, I encourage all of you to keep forging ahead in that it can be done, and to find the right people to help you get there. And so just a little bit about the logistics of setting up a telemedicine clinic in a mobile setting. We actually offer our telemedicine specialty clinic simultaneously with our medical clinic. So there is a lot going on, and the key is to, number one, stay true to your staffing needs. Make sure you adequately assign people that are trained to manage the equipment. We have telepresenters that we've trained to be able to present the cases to the specialists. In addition, utilizing the existing staff so that they understand the logistics involved with the workflow. And also just the planning of the telehealth clinics itself. This is all very calculated. We have set days of the month where we provide specific specialty services, and those patients are internally referred from our medical clinic, and appointments are actually set up, and the specialist is notified in advance, and they know their schedule and so forth. So it does take a lot of planning, but again, it can be done. That's just a picture of us. So just to tell you a little bit about where we started and where we're at now, it took us about a year to get our telemedicine program up and running. And through generous support, grant support, we were able to start a specialty clinic first, starting with dermatology. And that went really well, and we expanded our services to cardiology, endocrinology, and nutrition. And we utilize also store and forward technology for our dermatologists. We have applications on our mobile devices in which we can take pictures of special cases that need a consult, and we upload them to the cloud, and the dermatologist views the images and provides a consultation report after the fact. So we utilize both types, both live and store and forward for dermatology. And the cardiology clinic has gone very well. As we're able to, the heart sounds are heard by the cardiologist, and the EKG is read live, and we actually are looking into a portable echo machine so that we can also do echoes right there on site. And in addition, we have just started with a hematology service to try to improve outreach with our hematology department to identify children with bleeding disorders. And our latest project, which I'd like to spend a few moments to talk about, is an actual clinical intervention research study. It's the first time that we've actually done a clinical research program on the unit, and it's very much technology-based. And so what we hoped, our aims of the project was to measure the ability of technology to create positive impacts in children. And what we're looking at is, will this intervention of utilizing technology such as telemedicine, we have fitness bracelets, we have mobile devices that we're giving to the kids, will this intervention show that the ability of technology can create a positive impact in children and their families? And in addition, can this technology better enable marginalized low-income families to receive a group of coordinated care? So basically, we've taken this multidisciplinary team that we've built through our telemedicine program, and we're actually offering that now in a specific obesity intervention program. And so we're looking at biomarkers and changes in health behaviors and so forth. So we have an entire team. This is kind of a busy slide, but basically we have a medical team, a psychologist, a nutritionist, and an endocrinologist, and they all work through telehealth, communicating with the families on a monthly basis to try and make an impact on weight loss, on healthy lifestyle changes. We have health coaches that are assigned to each child that connects with them on a monthly basis via their mobile device, and they provide text messaging 3 times a week, distributing healthy lifestyle messages and so forth. So it's a 6-month program. We're right in the middle of it. We don't have any data results yet, but the initial feedback has been very promising, and we hope that this pilot can turn into a more comprehensive study utilizing technology. And so the future for us, we've got a few things going on at our institution. Well, we are looking at developing, taking the technology and developing a multidisciplinary team that will actually provide services out in the community through the Mailman Center for Child Development. And we hope on the mobile unit that we can expand our services to developmental pediatrics as well as speech therapy. So that's about it from me, and I appreciate everyone's time, and I look forward to hearing everyone's questions, and hopefully I can answer them. Thank you.
Thank you, Lisa. That was really great. And by the way, thank you all of you who have submitted questions. These are great questions. For those of you who haven't, feel free to ask questions of any speaker. We'll be pulling them and answering as many of them as possible at the end. Now, I know that many of you in the audience are not with nonprofits, but are interested in for-profit reimbursement models with telemedicine. We're fortunate to have with us Dr. Barbara Sheehan, Senior Health Researcher with Intel, who's going to help us navigate some of the latest news for-profit scenarios. Good afternoon, Dr. Sheehan.
Good afternoon, Matthew, and good afternoon, everyone, and thanks for joining us today. I'd like to start by providing an overview of the current reimbursement landscape in general around telemedicine. Sorry, the slide went a little too far. trying to go back. Okay, so here we are. My apologies. Okay, the slides will catch up. Currently, reimbursement is controlled at the state level. Each state has the ability to enact specific legislation that determines how telemedicine services are reimbursed in that state. These laws are referred to as the Parity laws. The Parity laws require that telemedicine visits are reimbursed at the same rate as in-person visits. And they outline specifically how reimbursement happens in each state. Currently, there are actually 29 states. I know the slide says 27. It's actually 29, plus the District of Columbia that have parity laws. And the specifics by state vary by several components. And these include things such as the insurance plans that are required to cover telemedicine, the eligible providers that can provide the service, the eligible patients that can receive the service, the patient location, which is also referred to as the originating location in the laws, the eligible technologies or the types of technologies that can be utilized, and any geographical restrictions that may be in place in a particular state. The map on the slide illustrates each state's status for this year with respect to their parity laws. And I do encourage everyone to check the American Telemedicine Association website for updates on the states. This is a rapidly changing environment. There has been expansion to these laws according to by the various states, but these components are different, so you have to know what the rules are for each state. Now I'd like to go into a deeper dive on a specific new reimbursement program under CMS that we think is a really exciting opportunity where telemedicine can really be of service. The Chronic Care Management Reimbursement Program was put into place by CMS and began in January of 2015. It was meant to support the primary care provider's ability to provide needed care management services for patients with multiple chronic illnesses in a way that would improve care while keeping costs at bay or reducing costs. The development of this program was driven by reports such as the one illustrated here by the Robert Wood Johnson Foundation that found that 84% of national health care dollars were spent caring for people with chronic conditions. And this is data that I'm sure all of you are very familiar with. The program is meant specifically to coordinate with other primary care program initiatives or payment initiatives such as accountable care organizations, the Primary Care Incentive Payment Program, patient-centered medical homes, and federally qualified health centers. And it is meant to appropriately value care management services within Medicare's fee-for-service structure. For the slide. Under this program, providers are required to provide 20 minutes of service per month. Eligible patients include those with 2 or more chronic conditions that place them at risk of death, decompensation, or functional decline. The 20 minutes that's provided must include establishment or revision of a comprehensive plan of care. And the scope of service includes access to those services 24/7, designation of a specific care provider, so the patient must know who their care provider is. The plan of care must be documented in the patient's electronic health record. An electronic summary of care record must be available for the purpose of care coordination, and also the patient has to consent for services. 99490 is the specific CPT code that's associated that you would use for billing for this particular program. So just to give you an example of the reimbursement for this program, CMS CMS allows for reimbursement at $42 per patient per calendar month for the 20 minutes of service. So for example, if you were to enroll 500 eligible Medicare patients from your practice, that would equal approximately $21,000 per month. And I say approximately because that can vary by state a little bit. So really the way to gain the most from this program is to be able to do it to scale. So then how can telemedicine help you to gain the most value while providing high quality care? While CMS does not really dictate what technologies and certainly doesn't state that telemedicine is required for participation, the kind of technology that we're talking about today can certainly help by enabling provision of non-face-to-face care in the patient's own environment. By having a visiting nurse or another healthcare worker bring a mobile solution to the patient, you can encourage better patient engagement in the visit. You can utilize those nonverbal cues that are so important. It enables assessment of the patient's environment, a better nutritional and fluid assessment, etc. Things that are really important in order to make sure that the visit is of a certain quality. But in particularly, it enables scaling the CCM service to more patients in the places where these patients are. So for example, places like over 55 communities, which can qualify as a place where the patient can be, an assisted living facility, residential treatment centers and rehab facilities. Those are places where there may be volumes, more patients, and the 20 minutes of service can take place across many patients. And very importantly, utilizing this kind of technology can help to enable tracking and accounting of the 20-minute time requirement per month, which may be very important in the event that CMS puts any auditing into place. So this is a very high-level overview of the chronic care management opportunity, and I do encourage you to access CMS's website for more information about it, and there's also a lot more information about telemedicine reimbursement in general on the American Telemedicine Association website as well.
You done? I'm done. All right. Excellent, Barbara. Thank you very much for that. Our final presenter is Dan McCafferty, Vice President of Global Sales and Corporate Development at AMD Global Medicine, Telemedicine rather. Welcome, Dan.
Thank you, Matthew. I'd also like to say thank you to Intel for sponsoring this program, Barbara for your expertise, and most especially to Dr. Lisa Gwynn for the great care she gives to the children of Southern Florida. Thank you, Lisa. My presentation is going to focus on three general topics that significantly impact and enable people like Dr. Gwynn's ability to provide telemedicine. It'll focus on some technological updates, the working environment, financial environment, and then perspective and forethought of people in this market, in this industry, and how to bring telemedicine forward. Oftentimes, it's worthwhile to look at history so that we can understand where we've come from and where we can go from there. I present you this slide which shows how telemedicine began so many 20-something years ago. It's what we call in the market in-band telemedicine. Let me explain to you how it worked many years ago and how things changed about 4 years ago. So in order to do telemedicine, people in the industry would take a video conferencing codec. A codec is a system that's purpose-built, typically with multiple DSP processing chips in it, with an embedded operating system, and it provides high-quality video conferencing between point A and point B. Provisioning that for telemedicine, we would use different ports or camera inputs or microphone inputs in the codec to put in medical devices and thereby enabling telemedicine from site A to site B. It required a switch to go from the face-to-face to, say, in this picture, looking at someone's eye. It was either or. you'd shut off the microphone and turn on a stethoscope, and you need decoding stethoscopes on the far side. This methodology treated millions of patients over the years, but it did have some serious disadvantages or drawbacks. First of all, this equipment tends to be rather large and rather expensive. The expense such to the point that typically a consulting doctor would have to go to a designated room and meet with that system. So the doctor had very limited mobility. It also had no ability to capture data, to put it into an EMR, and you weren't able to avail yourself of some of the evolving device technologies that use USB technology, because these video conferencing codecs are not PCs. So, approximately 4 years ago, at about the same time that Intel was putting transcoding capability in their CPUs, and AMD was looking to solve the problems of telemedicine then and try to move the industry forward, we came up with a product that we called Agnes. Agnes allows you to use a Windows appliance running an Intel processor. In today's world, that's called an i7 quad-core. It allows us to use USB devices, either of AMD manufacturer or from any one of our competitors, and allows that data to be aggregated to a web server that's within the Agnes software. It allows the local nurse or attendant to use a browser, as well as the remote physicians to use a browser, to be able to speak with the patient, do an examination, use any one of multiple different medical devices all at the same time. So people did not need to make a choice. It was not a video conferencing or medical examination. This is all one consistent experience for both clinicians, okay? So browser-based, you could communicate in real time with the patient and the attendant. You're looking in real time through the devices. You could exchange documents, prescriptions, lab reports. You can document the patient, review PAC studies, anything that's relevant to treating the patient in a clinical telemedicine setting. The advantages of this, we were able to dramatically lower the cost, dramatically increase the mobility of the clinicians on either side of the transaction, because we could deploy it in a browser. It gives us the ability to integrate to other applications, workflow products, EMRs, and increase portability. Dr. Gwynn talked about her program and her ability to be mobile, utilize 4G technology, put that in a vehicle, but also you have the opportunity now, because of the size of these systems, to actually even carry these into a patient's home and provide on-site treatment, which also is what Barbara was talking about with regard to reimbursement. That's the technology side. But for those of us in the industry, we have seen a dramatic increase of nationwide or even global acceptance of clinical telemedicine, regardless of where it's being performed, in a rural clinic or in the home. The financial benefits have become crystal clear. And it's not just about reimbursement. It's about convenience, avoidance of travel, the ability to more productively and proficiently carry through exams for clinicians. So it's about volume of patients. It's all of these things. So the environmental conditions are right for telemedicine. Our goal, and people in the industry, is to make telemedicine ubiquitous. We believe that with all the issues that we have within our healthcare system, that telemedicine can have a significant impact on helping to create a better environment for all patients. The way to do that was a commitment to having a true open system. Interoperates with any medical device of AMD manufacturer or others. It can integrate into an EMR with a product-based tool rather than a project. AMD saw that the market and the attitude needed to really change for, say, EMR integrations. These had to be easy, fast to do, and be reliable. And creating specific projects that had to be staffed with project managers and coders each and every time you wanted to do a new integration was really not a sustainable model. So we built a product that actually a customer can configure the system to talk to their native EMR. We also, from a perspective standpoint, thought that we needed to do something significant for the consultants that are wanting to practice telemedicine. Intel helped solve the mobility issue because now with their processors, we can deliver all of the medical information via a browser, which means just about any device is available for a consultant to use and to examine and work with the patient. But we wanted to take it a step further. So we wanted to make it access to be completely free and easy. So in the Agnes model that Lisa mentioned, all of the consultants that use Agnes to treat a child in Florida do not have to pay any licenses. They do not have to download any software. Nothing needs to be maintained on the PC. So any clinician from anywhere in the world could actually be part of Dr. Gwynn's program. All Lisa has to do is give them a URL and a password. So now I'll hand it back to Matthew for any questions.
Very good. Thank you, Dan. Very good. We do have good news. Our speakers were all very timely. I appreciate your keeping within our time limit, so we absolutely have time for a number of questions. Again, if you haven't have questions that you haven't submitted yet, please go ahead and send them in now. So, all right, I will start to pull from some of these. Give me just a second to pull up the questions tab, and I'll get going in just a moment. All right, so obviously a number of our speakers can answer different questions here. The first question is probably for either Dr. Gwynn and or Dan. What do you see as the key hurdles for expanding telemedicine in your area? So either Dr. Gwynn or, obviously in your area in South Florida, or Dan, what do you hear as some of the key hurdles that your customers are trying to overcome?
Well, I think that for my personal situation with our clinic, I don't see, the only hurdles I see is being able to bring on more specialists. Basically, that's it. From a technology perspective, there are no more hurdles. We've overcome those. So I would say just engaging more specialists on utilizing this type of technology.
Were there any particular hurdles that you faced initially that our listeners might be interested to benefit from your experience?
From a technology perspective, one of the things was basically setting up, we had firewall issues. Again, some areas we had to make sure that we had appropriate 4G connectivity. The other issue that we have to be careful of is the mobile units are made, they're made of steel and other types of metal, and we had to make sure that the way that the equipment was set up allowed us to have a good solid connection with our router. So that was kind of a logistical issue. And also, if we have other laptops utilizing the EMR and pulling some of the bandwidth, if they're seeing patients in other rooms, sometimes that can affect the quality. And what would typically happens if the signal, if that happens, we have the sound might go out, and we still see the picture, and the specialists can see everything on their end. So if that happens, we kind of peek our head out and say, is anybody using the EMR? And if they say yes, then we have them log out. So it does not happen very often. But again, I mean, I want to share with the group that's been the biggest things that have happened, basically.
Okay, thank you. All right, next question. You were talking about the EMR. Can you comment on EMR integration? And did you use a separate EMR or access the existing system? So this could be, again, for you, Dr. Gwynn, or more generally about EMR support for Dan.
Well, I can just tell you from our experience, all of our specialists are within our health system, so we all utilize the same EMR. So to generate a note, it's not a problem. We have a template for that specialist, and they go in and they create their encounter, and that isn't a problem. But if you want to upload images, we have not been able to accomplish that yet. So, if we want to, for example, put the EKG, upload it into the system, we can't do that yet. Or images from dermatology, we're not able to do that. But we are able to, again, the specialists are able to create a note in our electronic health record.
Okay.
And
Dan,
Matthew,
do you want to make any comments? Yeah, go ahead.
Sure, this is Dan. Surprisingly, many EMRs don't have the ability to save, say, an image from an ENT scope. And of course, that is surprising. But what AMD has done with its latest release that will be on its way to Dr. Gwynn shortly is we've come up with a configuration system that is almost as simple as filling out a form and checking boxes. And it allows you to take any information that you've captured through the telemedicine encounter, and you can automatically then send it to any EMR via HL7. So within the Agnes product is a HL7 engine. You have already told it exactly what the location of the EMR, who's the manufacturer, all the technical details, and you tell it how you want the files sent to where. And it's really as simple as that. It works wonderfully. It can be configured in minutes. It doesn't require an IT project.
Well, that sounds great, Dan.
Good. Even our speaker is learning with today's webinar. So all right, next question. Also for you, Dr. Gwynn. How is patient follow-up handled afterwards? How are patients monitored?
We don't have any home monitoring other than in our obesity study. We have information that's gathered from the Fitbit bracelets. It's actually uploaded into a database, and we keep track of those kids that way. But in terms of the other, we don't have any home monitoring for medical purposes, if you will. As far as follow-up, that's part of our workflow. We have a form. The telepresenter actually takes notes during the visit, and if a follow-up appointment is needed, that referral is written right there on the spot. So we make sure that those kids are followed up.
Great, thank you. And actually, I love this question because, Intel's also involved in remote patient monitoring technology and also population health technology. So hopefully we'll have some webinars that talk to that in the future. I don't want to say last question for you, Dr. Gwynn, but one more for you for the moment, and then I want to give Dr. Sheehan and Dan a chance. Many people think Google Glass is the future of telemedicine. What's your opinion on this? Would you wear Google Glass during a visit with a child?
I have to be honest, I do not know a lot about Google Glass. I know it's been spoken of in telehealth circles lately. I really feel like we have too much to overcome with the basics, such as making sure standard of care is appropriate, if we get reimbursed for our services, all the issues with licensure. We have so much that we need to get worked through and ironed out before we go on to Google Glass. I can't imagine, going to insurance companies and saying, will you pay for this visit with Google Glass? It sounds very innovative and fabulous, but to be honest, I haven't even gone there.
Okay. Yeah, I'm sure that there are others in the industry that are absolutely looking at that. Certainly Google Glass does provide, video streaming. So I guess we'll say stay tuned for that one, and hopefully we'll be able to cover that as well in the future.
Well,
So,
Matthew,
yeah, go ahead, Dan.
This is Dan. One of the things that again, go back to history so you know where we've come from and where we're going, right? Google Glass could be a very good tool for the presenter side of the telemedicine encounter. But early on, the biggest hurdle for telemedicine was to prove to people that the patient's experience was appropriate, or at least the next best alternative to a face-to-face. But Google Glass, you forget, it doesn't help, it doesn't give the patient the experience. It allows the presenter to have basically a view back to the consultant. But it does very little for the patient. You can't visualize the consultant side at all. All right, so it's a tool, but it's not a panacea.
Sure, of course. I mean, what you're doing is you're enabling the specialist potentially on the back end, to be able to see things they might not otherwise see. But certainly, I see where you're coming from. So, Dr. Sheehan, quick question for you regarding reimbursement. Can you bill for telehealth services and CCM services together?
So again, the question was, can you bill for CCM services and telehealth services together? And the answer to that is yes. The CPT code for CCM, for the Chronic Care Management Program, is 99490. That can be billed with CPT codes for telemedicine. For example, CPT code 99091, which covers collecting and reviewing patient data and remote monitoring services. There are additional CPT codes under the CCM program that enable billing for expanded service. So if the time spent per month goes beyond the 20 minutes, there's additional codes for that. And then there are also new CPT codes that were introduced this year that cover things like annual wellness visit, even psychotherapy, for telehealth that can be bundled with the 99490 code.
Okay, thank you. And I guess another question, probably in your area or maybe Dan's, are there any states in which reimburse for visits in the patient's home, and does it vary by state?
So for me, I would say the answer to that is yes. The home can be considered a originating site where the patient is. Yes, it does vary by state. That is covered in the parity laws. So each state may have some variability where that is concerned, but that has definitely expanded.
Okay, and I assume the American Telemedicine Association would be the place to go to find out any variations by state.
Yeah.
Okay, great. Dan, question for you. Can you comment on latency performance of the Agnes system and teleclinic?
The latency. Well,
it's just performance. Yeah, go ahead.
Sure. The application is designed as a dual video stream. So, for instance, live video conferencing and streaming from, say, an ENT scope or an ultrasound probe, which is the worst case computational workload on the originating PC, if you will. All right. So it's designed and provisioned to be full real time. Any latency experience would be purely due to the network it was riding on. So if you had a particularly weak internet link, then you may in fact experience some amount of latency. But in normal conditions with a good internet connection, you'll experience very small latency, which is just part of the physics of transferring data from point A to point B.
Okay, great. Thank you. Another one for you, Dan. Do you have any customers who are using this as a means of preventing 30-day readmissions at this point? Is anyone using the teleclinic to go check up on existing, post-acute kind of scenarios to avoid readmission?
Yes, absolutely. Absolutely. And the things that have been really important, I just glossed over it, but there have been some very great advancements with wireless antennas and amplifiers and things. And the big enabler for those folks going into people's homes is companies like Cradlepoint, partnering in with AT&T or T-Mobile for the technology so that it's really seamless. When people go into the home, they get good performance at a very reasonable cost out of the network.
Great. Thank you. All right, next one, probably for all three of you. Does Medicaid reimburse, and does the mobile clinic qualify as an originating site?
So I can try to answer that first. Medicaid does reimburse. That also is something that's part of the state parity laws. So it does vary depending on what Medicaid programs are available in a particular state, and whether the state requires Medicaid to reimburse for this. But in general, the states that have parity laws do require that Medicaid reimburses. The Medicaid programs are part of that. So what was the second part of the question? Does
the originating site, does it mobile clinic qualify as an originating site? And they also talked about the smallest vehicle which might qualify as an originating site.
Yeah, I think the issue there is that as long as it is considered a clinic.
So, yeah, I have,
good.
well,
Go
we
ahead.
had some issues in Florida. Again, it varies by state, but I know
Yes,
for
it does.
Florida, they're actually, we just were able in the last 2 years be recognized as an originating site without being, in years prior, the regulation stipulated that the mobile clinic had to be part of either a federally qualified health center
Right.
or a county health department. And we were able to actually get that regulation changed so that we could, they changed the language so that if we're affiliated with an accredited medical school, so we could bill for Medicaid. Now, we're just getting into that with regular medical claims. We haven't explored the whole arena within telehealth at this point. You know, so far all of our services are grant supported.
Okay.
Right, so I think that as Dr. Gwynn said, that there is variability by state in terms of what kind of vehicle would qualify, but it would have to be a designated clinic of some sort.
Got it. All right, next one's a fairly common question. Does the provider need to be housed in or licensed in the state where the patient lives?
This is actually a point of a lot of contention, I think, with telehealth. There are states that allow the provider to be in one state while the patient is in another. For example, I think Ohio, Illinois, and Indiana allow for that, so the provider can be licensed in one while the patient is in another one. But that is something that is being, I think, discussed at many levels, how that can work with the licensure requirements. But there are states that do allow cross.
Right. They call it reciprocity, and in some states, well, in Florida, there aren't any regulations on the books yet regarding that. There's some bills that are going forth in the legislature now, and that has, as she said, it's been a real contentious issue, and some states are moving farther along than others. So again, it depends on what state you're in as far as, you know, what you're able to do.
Right, and where your patients are. And I think some of those states that really are, you know, very close together are probably working it out a little bit more where that might be a more common scenario.
Okay. We have time for a couple more questions, but I do want to make a quick plug. American Medical Devices, Global Telemedicine, and Intel will both be at the upcoming mHealth Summit, November 8th to the 11th, at the Gaylord Hotel outside of Washington, D.C., and booth 703. So absolutely would love to have you guys come up and tell us you heard us on the webinar, and be able to ask as many questions as you want. So just a couple more questions, and then we'll end for today. With the Agnes interactive browser-based technology, what IT infrastructure, so it sounds like this is for you, Dan, or equipment is needed for the remote or consulting physician? And so,
well, that's an easy one. That's an easy one. That's an easy one, Matthew. The answer is absolutely nothing. Once the software, Agnes software is installed, whether it be on a portable teleclinic unit or a laptop in an exam room or on a mobile cart where the patient is, that system is all that's required. That's a fully functioning web app, basically, and the consulting clinician who could be 10,000 miles away only needs that web address, that URL, and a password. So there is no other infrastructure required, and that's one of the beauties of how this thing's built and how it's deployed.
Excellent, excellent. Someone asked about the pediatric model. Would it be possible to use the pediatric model for adult weight management programs?
Sure, why not?
Sounds great.
Awesome, awesome, awesome. All right, I think, again, I want to leave a couple of minutes for you guys to get to your next meetings. There were a whole host of questions I apologize we did not get to, but we absolutely, we have your names, and if you filled in your email addresses, we'll absolutely be going over those questions. So again, thank you everyone for attending today, as well as our speakers. Could not have done this without you. Thank you for your valuable time and insight. And with that, I'm going to end the webinar for today and wish you all a good day.